As many know, Professor Vertinsky was a professor in the Sauer School and also at the Institute of Data Research, and has been our distinguished colleague in the MCRI project on coordinated lines for many, many years. So we're just delighted that Ilan has agreed to join us, and we've joined him.
Thank you. Okay, how long do I have?
I think you have about 40 minutes, and then we'll have 20 minutes for questions.
Because I have a 3-hour presentation and a 2-hour presentation, but I'll try to make it shorter. No, I will stop. In fact, by the way, I was going to start with the conclusions, so if I don't get to them, but what I'll do is, when the time comes, after 45 minutes, I'll stop and move immediately to the conclusion. Okay. It's just trying to describe a system, actually two systems, okay? The intellectual property system and the health system, and put them together is not easy, and it's quite complex. And also, by the way, this is work in progress, it's not finished, but I think there are a lot of stories that can be told, and I'm trying to just find out which one actually will move.
Sorry, I think I could just do sorry, actually, this one.
I just want to move on. Usually it's one of these two. Okay. Now, you need a lawyer to solve all your problems. Really, it's a multifaceted profession, right? Okay, so I would not go through the agenda, but that if I presented everything I have, I would have basically would describe two systems, and so let's start with the presentation itself. So I just as a means of introduction, this project is part of the MCRI, as Pittman suggested, and the focus of the MCRI project at this particular point is coordinated local compliance with international treaty obligations related to trade and human rights. The specific case study that I will describe today is China's obligation to supply affordable essential medicines under human rights treaties versus compliance with TRIPS obligations to protect intellectual property rights of pharmaceutical companies. So, just intuitively, you can figure out that when you have patents, you have monopoly rights, which means prices go up. And that contradicts, at least it appears to contradict the notion of affordable medicine. Part of the story that I'll go through, okay, and provide a lot of details, is showing that the system is not as simple as that, right? You have property rights, and you have obligation to comply with them. And then you kind of, and the question is, how do you do that? Yet in the same time, complying with something that is contradictory. And I think so. As I will later show you, that actually, in the formal sphere, in the sphere of law or international law, TRIPS actually provided for possibilities for coordinated compliance between health and trade. In fact, there is a declaration that is called the Doha Declaration on Health, on TRIPS and health, and they basically provide authority to countries to look for flexibilities within their patent systems so as to provide for health rights. Okay? As you will find out, that's not necessarily the story as it happens. And so what I will be doing, I will first of all go through the health right, the whole idea of providing affordable medicine, which is part of health rights. Okay, as you will find out in a second, it's actually one of two legal obligations you have if you want to provide, to comply with health rights. You will find out that health rights are, so far ideal that nobody, no country actually achieved it or will achieve it. It's provide the best possibility for health care or for promoting health. Then there is, of course, always a cop-up, possible. And then the question, what is possible or not? So it's very vague. But there are two legal obligations. Okay, and I will tell them, though they will come in a second, I'll tell you now. The two legal obligations is basically increasing the health budget each year. And the second obligation is to provide affordable essential medicines as defined by some list that WHO provides. So, first of all, about health rights. Okay, there are a variety of treaties, but the important one that defines that define two legal obligations is the International Covenant of Economic, Social, and Cultural Rights. And without going into all the verbal declarations and all the articles of interest to us is the obligation to provide affordable essential medicines, and this particular right is threatened by patenting. There are other, as you will find out, there are other threats. And in fact, one thing you will find out later in my talk is that patenting would not have been so much of a threat if there was no force within the system that pushes, provides incentive for prescribers, providers of healthcare in China to actually divert people to expensive medicines, because the system is based, the financing of the system is based on making money out of medicines. And of course, if it's based on margins, if you have something expensive, you get bigger margins. You don't need to be a professor in Soder to figure that out, okay? And so if doctors can be paid more because they get bonuses, they're underpaid and get bonuses on the basis of the hospital profits. And if the hospitals are based on funding it, as long as no funding is provided, they have incentives. So you may give me a list of essential medicine which are cheap. If I want to make money, okay, I will push for medicines which are expensive and are not on the list. And actually, if they're not on the list, they're not reimbursable, even if insurance is offered. So this is kind of the basic story in terms of affordable medicine, but I'll go through some details. Then add, by the way, to this story about 15 agencies that have different interests but have a say and control on medicines, on the supply of medicines, and you start getting the idea that things may not go so well. But let's first of all look so just in terms of the obligation, again, WHO essential medicine list is renewed every once in a while, but it includes at the moment, in 2010, 350 medicines. Most medicines are not protected by patents, so really compliance is easy. Okay, you can have patents, but they are not, these medicines are not. So it's pretty easy to comply. But the problem with that particular list, it's irrelevant. It tends to be obsolete in terms of new available effective medicines. It does very well on medicines that develop to infections and communicable diseases. but not chronic diseases, and especially not cancer, diabetes, all those diseases. There are some medication in it, but they are not the most effective and they are not new. So just imagine, by the way, if you can afford anything, and somebody says, but this is a much better medicine to save your life, you may very well choose the expensive medicine, and I'll give you some statistics. But before even going to this particular kind of to essential medicine, let's see just how the achievement of China. What China have done in terms of, and how did it progress in terms of actually moving the health system forward? And they've done quite an admirable job. So some of the achievement. Look at life expectancy. 2071 years, 2010, 73. Canada moved half a year from 79.2 to 80.9. By the way, I always put Japan, and I find that Japan spends less and gets better health. So in some ways I should give in our lecture about China's healthcare and how we should try to improve it. It costs more, but you get less. But anyway, I put for comparison India, and you will see some progress, but India usually dedicated less resources and progressed much less. So health expenditure per capita, that doesn't mean that it all contributes to good health. Maybe the good health of the doctor sometimes. But China spent $44 per capita US dollars in 2000 and 221. That's kind of big increase. And when you think of the size of the population there, that's huge investment in health. India did much less. Again, when you are spending $20, doubling it is easy. Okay? But if you look at China, it's more than doubling. And if you're looking at communicable diseases, just look here at China and Canada. From 85%, and even 10 years ago, they already were immunizing large portion of the population to 99%. India at 72, Canada in 95, Japan 98. Under 5 mortality per 1,000 births. These are the things that actually where you can gain a whole lot with little money. Okay, when you cure cancer of older people, it's not as impressive, but it's important. Okay. So again, China here 35 people per 1,000 births. Down more than, to less than half, okay? And so it's great progress. I mean, one have to celebrate the achievement of China. Now, health services. Here actually comes not necessarily, it doesn't necessarily save your life, etc., but it deals with people. Okay, it cares for people, so maybe it saves pain, maybe it also saves life. Though, by the way, the measure of how many lives, a reduction in mortality or increasing lifespan is a good measure, because many times you can spend a lot of money making people more comfortable, but not necessarily providing them with something that makes them healthier. It reduces pain, increases the standard of living, etc. So let's look. Health spending is now about 5.5% of GDP. It's pretty sizable and going up. It's less than in Canada or the US, but it's going up. Accessibility and affordability are key reform objectives, and let's see what they have done in these terms. In 2001, 60% of healthcare expenditures were out of pocket, and less than 30% of the population was covered by healthcare insurance. So, by the way, coverage in terms of how many people, I can cover everybody and cover nothing. Okay, so this is always this, and China was covering more and more people, trying not to cut too much of what you get. And at the same time, but over time, the demands, the needs, the expense of covering what you need are going up. So you'll find out that Chinese people pay more of their pocket, of their family income, on health. Of interest, by the way, will be, and I will give you the numbers, of those who have what we call catastrophic expenses on healthcare. Okay? And it's quite sizable in China, but again, there was a reduction in those. So again, accessibility, by 2011, approximately 96% of the population was covered in response to insurance reforms taking place between 2003 to 2008. The period between 2008 and 2011, so of course, when you get to the top, it's very difficult to cover the last 1%. Okay, you first cover the people which it's easy to cover. So you can see the decline, but altogether, 96% is pretty good. Now, important, however, part how much of the expenses were covered. Not just how many people, but how many, what is the percentage. So the inpatient reimbursement rates in 2011 were 47%. The share of household income on healthcare, however, climbed to 13%. Now is a story about affordability. Households with catastrophic health expenses constituted about also 13%, but it's 173 million people. Okay, so 13% doesn't sound much, but there are definitely huge amounts, several Canadas, who don't get, who basically are destroyed by healthcare expenses. 28% of patients discharge themselves prematurely for financial reasons. Which again, indication of lack of affordability. Most programs reimburse mainly for inpatient care, not outpatient. The outpatient coverage and coverage of drugs is significantly lower, unless they are part of the Chinese essential medicines list. Okay. So, but still, you think this is great progress. Okay, this is the healthcare as a whole. Now, severe disparities in rural and urban, and by the way, this data is quite reliable. It came out of a survey that was done by foreign experts with Chinese experts rather than the actually survey of people, not what hospital reports or agencies report. So this is quite, I mean, as far as surveys are reliable, it's quite reliable, okay? Because I was trying to sort some Chinese reporting of numbers at their agency, and they're not always consistent, but it seems that in the healthcare system there is more people who are willing to come and say, at least there are some critics who haven't yet banned, okay? So, and maybe that's a new phenomenon, I think, after the SARS kind of event. But again, the disparities are big. But now this is a commitment. This is not really expenditure. In 2011, the government committed to increase investment over 3 years to 1.13 trillion RMB, which is about 173 trillion, and it's about $173 billion when the rate of exchange is 6.6. So just, I think that's the number. But they are spent on upgrading of the facilities, okay? Basically, hospitals and clinics. And the push is to get more things and more coverage, not through hospitals, but through the clinics or grassroots clinics and other kind of facilities. Primary care going. And by the way, the biggest offenders in terms of affordable medicines, I will tell you in a few seconds that these are the tertiary hospitals, and not necessarily the rural clinic okay. And because of this funding system that I mentioned. Now, the national, going to drug now, more directly, the National Essential Drug List under the National Essential Drug System applies to government, and I will go more right now I'm trying to give you some data, and later I'll talk about the policies, okay? So applies to government-funded hospitals, grassroots clinics. The 2009 list contained 307 drugs, 205 chemicals and biological drugs, and 102 traditional Chinese medicines. These medicines, not just the traditional, all these medicines on the list are subject to price control. Provinces can supplement the list, and they do, but depending on their financial capacity and needs. So if you are on inner China, you are less, West China, you are definitely covered for less, and you have availability. By the way, these drugs are not always available, so it may very well be on the list and it's cheap, but because it's cheap, nobody produces them and it's not available. So that's kind of part of problems of reform, when you have good intentions, but you manipulate one side of the system and you have. This is even if everyone had the right incentives and try to do the right thing. Doing the right thing in a complex system is not so easy. Isn't it the road, is it okay to say the road to health is paved with a lot of good intentions, or is that sacrilegious? No, it's not sacrilegious. Okay, I get approval. Okay. Okay, all listed essential drugs are included in China National Reimbursement Drug List, so that's these two systems are synced and enjoy higher reimbursement rates than non-essential drugs. China's share of spending on drugs out of total healthcare expenditures is very high, about 50%, which is compared with only 13% in the US. So now, thinking about this, however, if you look at the dollars that are spent per person on drugs, they're much lower. China is one of the lowest in the world, spending $35 US. This is the 2009. So when you're looking at the share and the importance of medicine in the reform and the financial importance of medicines, which is part of the story of the political economic story that will explain why, when the formal system is there that allows this coordinate compliance, it doesn't happen. Or it happens, but with difficulty. Okay? So medicines expenses should doubled in size in the last decade, burdening the public purse and also households. Because, as I said, the reimbursement is limited for outpatients and those who basically buy the medicines, from pharmacies. Now, part of the major things where patent actually starts getting, as I said, the things on the essential list, essential medicine list, mostly are generics and they're not patented. Okay. China is facing, however, major epidemics of chronic kind of disease, cancers, cardiovascular, and respiratory diseases, which account for more than 85% of total death in the country. I mean, that's not surprising, because people die eventually from something, okay? And age is highly associated with cancers and unfortunately all kind of other diseases. But and annual cases of cancer have reached 2.8 million, 20% of the world total, while 1.9 million people, or 24% of the world total, die of cancer annually. This is now in China. It's not all just the population is aging, lifestyles are changing. There are urban lifestyles which are not always healthy, and what also happens is pollution. I assume most of us have visited China and did not enjoy the fresh air, right? Apparently it's getting worse than it was, and I didn't think it could. China has become heavily reliant upon imported patented drugs to treat conditions like cancer. So more money is spent on chronic chronically related medicines. Most of the effective medicines are new and patented. By the way, even if they're not patented, they're branded. Okay? And if you have prescription that pushes expensive medicines, you go to the doctor, and the doctor in the outpatient clinic, and the doctor sends you to the hospital pharmacy and suggests that you should have this brand and not that brand. Even if they are completely identical in terms of effectiveness, people tend, one of the reasons they go to the outpatient medicine and buy in the pharmacy of the hospital is they believe that the quality is higher and the effectiveness of medicines there is higher. So here you have now a system where they are pushed to buy these medicines, and those are not covered. So branding and patenting are key drivers. So patents is important because patents are really granting somebody a monopoly, and therefore the monopoly is useful because you can charge higher prices when the demand is relatively inelastic, which means it's if you limit the quantity, you can charge more. Okay? You will find out in a few minutes when I'll talk about all the question of affordability and what makes things affordable or not, that in this segment there is very little competition, because if you have patents, then you have monopoly. If you don't have patents, but you have the patents expired, but you buy the branded, you pay more, double or triple for the branded medicine. Maybe you can either change the prescriber, try to affect the prescribers, or you should educate the public. But when it comes to the health of my family, I always will buy the best, right? Wouldn't you? And the best may not, by the way, be best. In fact, there are studies that the use of expensive antibiotics, it's huge in China for common colds, which are not affected usually by antibiotics, etc. And one measure to look at bad prescribing is surveys that look at the use of antibiotics, etc. And all of them are expensive and are not covered. The whole idea of the essential medicine is also to direct to right prescribing. But people don't. So, by the way, these numbers, however, the idea that, for example, some cost of medication can be upward of $80,000 per year, compared with an annual per capita income of $3,000, suggests that you are not going to do too well. So factors affecting the access to medicine. So this I'll just give you some theoretical framework of what we're doing. So first of all, dimension of access. What is access? Well, first of all, availability of supplies. And that, by the way, especially in those cheap medicines, in many regions, they're not available. Okay, you go there and you don't get it. Price, clearly, if you can't afford it, price is important. Quality, and here all the regulatory system that tries to assure quality is actually lacking in China. And that's one reason why people would also prefer to buy branded medicines, especially foreign brands. And so when looking at price, that brings about affordability, okay? Because affordability combines your income and the price. And access to affordable and unbiased consultations, that's part of access, that you will get the effective medicine and the right medicines. So, factors affecting access to medicines: poverty, lack of knowledge, irrational consumption, anti-competitive practices and marketing practices, and this is including all the incentive, but monopoly, having very faulty supply chain, okay, and we'll talk about that, and a lot of intermediaries in the system. Availability and distribution, that's part of the intermediaries. And so possible remedies, okay, and I highlighted in red, the ones that actually are relevant, are the most relevant to existing policies. Well, price controls, we talked about that, and I'll come with more details. There are no anti-branding laws and regulation, but the regulations are, in terms of reimbursement, there is a push away from branded. Less, they will pay you less back, and there is a push. Compulsory licensing. As you will find out, this is a tool, but was not used ever in China, formally. But there are all kind of informal ways of where you actually have a patent, but you don't. I mean, you have the patent and you're happy, but the system is such that you can register the patent, register the medicine, which allows you to sell it, and there is no link between the patent office and the registration office. They are different agencies. So, and I'll discuss it in a second. Insurance, there are other patent flexibilities, and I will talk about some later. And then insurance coverage increases. And of course, there is, when I will tell you about the structure of the pharmaceutical industry, a lot of kind of not this fancy branded medicines, but a lot of medicines are being produced by many small producers in a very fiercely competitive market. But the cost, having an inefficient system, even if they are not making a lot of profit, the costs are higher. So another kind of way of dealing with cost of medicine is also increasing the efficiency both of the distribution system and the actual production. Interestingly enough, the ones that I put in red more or less were part of different policies on the health side that kind of try to advance affordable medicine. So let's just talk about the pharmaceutical industry. And by the way, I'll stop at 10 to 6, okay? So I'll start jumping on things. But I thought that getting kind of the lay of the land here is important, okay? So first of all, total industrial output value increased in the past decade at an average annual rate of 20%. China will become the 5th largest market by 2020. Now that's a projection. And the Chinese pharmaceutical industry will rank 2nd in the world after the US. This will include also, of course, foreign companies operating in China. Now, the reason I put these facts is later I want to kind of get quickly to the political economy. Who pushes for what? And the promise of bigger markets gives the government room to negotiate with stakeholders, like foreign companies, in the sector, but also may tax its capacity to bring about reform. Okay, so a very expensive system. Everyone is looking, it's a growing system, the drug companies to be there, and in fact China uses it to extract large discounts. So many times I suggest that some of the tools, like I said, compulsory licensing is not used. It doesn't need to, it's there, and you don't need to use it when you go and negotiate centrally about discounts. If you don't pay the price, then you will get less when we compel you to license it. Okay, so the drug market comprises a complex system of regional markets where manufacturing is dominated by generics and the majority of sales are over-the-counter drugs, huge amounts of money. China's prescription drug market became the world's 3rd largest. A key driver to growth is demand for cardiovascular hypertension drugs. The cost of prescription drugs is forecasted to reach 442 billion RMBs. An average annual increase, so the average annual increase over the last decade, actually, it's bad English, increased by it was 27%. So you're dealing with increasing costs. Now, the pharmaceutical industry consists of two distinct subsections, as I already mentioned. Thousands of small domestic producers, almost in free competitive market, and they're competing on price. But they can't charge less than it costs them. So when essential medicine has a ceiling of what it costs, they stop producing. Okay? Move to something else. And 20 foreign enterprises dominating the drug market of high-end hospitals that import branded new medicines. Okay, and that's lots of the money goes there. Foreign corporations, including the world top 20 pharmaceutical multinationals, as well as companies from Taiwan, Hong Kong, and Macau, command 60% of the profits generated in the industry. Okay, so the small, many that sell maybe the bulk of medicines don't make profits, not make sufficient profits, and the quality, by the way, is reflected. So it's cheap, but not necessarily high quality. So this, again, by the way, this our objective of reform is to try to consolidate the industry, make it more efficient, and then deal with the distribution system. I wouldn't go through the history of the supply chains and the distribution, but this is another thing. Okay, so planned economy. Actually, it's interesting to look at it. In the planned economy, drug manufacturers, you had a couple of tiers, and everything was not much was sold, not much was consumed, but it was pretty straightforward. Then 1980 to 1999, there was the regulation of the drug distribution, which led to fragmentation, led also to high, and maybe I should go to kind of a lot of intermediaries with very large profit margins as you go. So you start with the producer. Now, if it's a producer who is foreign producer with branded medicine, it starts with a big price and goes way up. But even when you start with relatively cheap prices, by the time you add all the distribution. So big intervention was to try to reduce the number of layers of intermediaries. And the second kind of, and you see, yes, patents play this, but even without patents, there is a lot that can be done to achieve affordable medicine by reforming the system. And you can see just some of these numbers, hospital sales 20 to 50%, kickbacks to hospital personnel, doctors. You have all these things that happen even at one level, let alone when you sort of go all the way down, every time it moves. So there were different attempts, different rules, and different. But as long they have to cover only specific things, and they don't cover all medicines. They cover essentially the essential medicines. So again, they increase the incentive for doctors and hospitals to divert patients into the more expensive ones, which are not covered by some of these regulations. The other thing, even when there are regulations, they're dealing with, recently there were some, on an experiment basis, they put more strict regulations in experimentally. The problem is that unless they provide also funding for the hospital, and Yoel probably can tell us more about what's going on that, he's working on it, they have, even if everyone was just trying to have the system survive, they will have to use, as long as you don't offer an alternative, these expenses will go on. Now, this could last, by the way, I had 10 PowerPoints, which are not here, talking about each ministry and each agency and what they do and what their objectives. Okay, and I wouldn't go through the story of anything, but I will highlight the State Intellectual Property Office because we are interested in patents, and the Food and Drug Administration, okay, which actually is responsible for registering medicines. And I already gave you sort of a hint of the story that comes there. But anyway, if you're looking at this, this is not the full list. And you start thinking, what is Ministry of Health probably, the mission is to provide health, affordable medicine is important. They are charged to do so, okay? They charge also in part, with the reform of the system. There, by the way, the secretariat, or provide the secretariat for the National Committee on Essential Medicines, which is the committee of all not of all, of the important participants, the people with direct impact on drugs. And by the way, all these agencies do have some impact on policies concerning drugs. So the Ministry of Health wants to provide. The State Food and Drug Administration, actually, the way it at least acted, and some of the regulation that guides it, tries to push for quality of medicines and for affordable medicines. Okay, they tried. So they, in a sense, do the registration. They provide the registration, and there is a direct revision in the law that tells them you cannot stop a registered drug on the basis that it infringes patents. This is an official policy. So no, this is not part of the TRIPS or part of the patent office, but it's it's part of the rules that guide drug registration. And once you have a registered drug, it's in the system. Okay? So again, you can see what the maze. But then ministries such as the National Development Reform Commission, which is interested both in providing health, in pushing it, but in the same time has also development objective. And drug is an important, it has great future. Before I mentioned, great future, it's big market, but the drug industry can be a maker, and this is the objective, to make it second to the Americans. Okay, and in order to get the technology, in order to attract, you need you cannot scare the foreign. So again, this, even the same agency may have conflicting objectives. Now, when you put them all together and mix them, and they all have something to say about the policy, and they also, many of them are involved in the implementation, you get a problem. Ministry of Commerce, for example, is interested in, again, attracting foreign direct investment. It's in charge of this legislation. It also, it want to promote. It also have interest in competition and in the prices, in the pricing of including prices of medicines. So, and it also have to comply. It is responsible for complying with TRIPS and essentially all it deals with international relations, economic relations. So within it has different divisions that push for different things. Okay. Ministry of Finance, Ministry of Finance always want the money, right? And they have to provide the money. Ministry of Science and Technology, again, is interested in pushing for development. And in the long run, by the way, that's very good for China. But in the short run, that means don't rock the boat too much and don't scare the investors. Okay, now you put them all in the National Committee on Essential Medicines, and it's like you get soup, duck soup, whatever. It's not very clear what's happening. And so I said there are many other ministries and agencies that have partially overlapping mandates to deal with pharmaceutical. The National Committee on Essential Drugs represent one of the key coordinating inter-ministry, inter-agency mechanism with respect to drug-related policies. The committee is composed of representatives of very important ministries: Ministry of Health, the National Reform Development. What is the last C? The C stands. What? Commission? Okay, Commission, and the Food and Drug Administration, the State Food and Drug Administration, etc. By the way, even the Ministry of Commerce and the State Administration of Chinese Medicines, they are very interested in patenting and stroke patenting. I don't see, by the way, actually the patent office, but the Department of Commerce is represented, which is also indirectly responsible for that file. Okay, I don't have much time. Let me go. So again, the variety of policies and those who want to get the PowerPoints, I'd be happy to send you either the short or the long. The long actually provide even more details, but this is the shorter one. But price setting, this is now part of the, I'm talking now about the policy of the national policy of of affordable essential drugs. And so the guidelines and the policy was introduced in 2009. And there are interesting guidelines for price controls. Like, for example, taking the price of the brand and the generics and say that you cannot have the patented medicine different by so much, okay? Or the branded medicine than the generic, the unbranded generic. So kind of this way you provide them a profit margin and you recognize, but you keep it tighter, okay? But these are things on the essential list. If they're not on the essential list, it's a freedom. So the guideline resulted in 60% reduction of prices of domestically produced drugs, but only 25% of foreign branded drugs. Okay, were to start with very expensive. Elimination of the 15% markup for medicine on essential drug list created incentive to prescribe medicine not on the list. And this is always a problem. You know, you can develop a great policy, but look at the incentives of people to violate it. Okay, the implementation covers quite a bit, but not everybody's actually implemented the policy. And I again emphasize lack of sufficient funding to public hospitals who rely on sales of medicine. Only 10% of public hospital funding is received from the central government. Some of it is received from provincial governments and local and that. But these are really, some of them are pretty poor. So if you have Shanghai, probably you get a better deal. It's a rich city government, okay. But in many places, and by the way, what is on the list of affordable medicines, essential medicines, is different. Okay. Now some of it makes sense because certain medicines are appropriate in at least China didn't come with the idea of WHO. There is global list, okay, which they at least try to adjust it to demographics and to geography. But economics play big things. Now implementation barriers, kickback and prepayment are rampant. Corruption is everywhere. Lower drug prices discourage domestic manufacturers from producing drugs, resulting in shortages and substitution to more expensive drugs. Power struggle between government agencies over policy implementation. Tendency to expand populations covered without sufficient funding, resulting in reduction in what is covered. So you say, great, we will cover 100%. They probably can't find 100%, right? 96% is 100%, okay? Now, I already mentioned the drug registration, I'll skip it, but the drug registration was in some ways beautiful. It allows you not to deal with you can actually reduce the impact of patenting by by having this dual fragmented system. Now, one may have thought that maybe just, bad bureaucracy, but in fact, there was a revision to the law that says, 1 minute, guys, you started looking at the linkage, the information linked to the patent system. Don't do that. Okay? So I try to call it uncoordinated compliance rather than coordinated compliance. Now, TRIPS. This is, by the way, I assume that everyone knows, but this is basically under WTO is the agreement that deals with intellectual property, and it requires a minimum protection for all, and suggests that the scope of patentable subjects is very broad. Okay, like India some countries, not just India, but used to exclude medicine from patenting, from protection. Under WTO, under the TRIPS agreement, you do. But as I already said, the TRIPS, given public pressure of NGOs, Doctors Without Borders, actually played a big role in pushing on the AIDS kind of domain for compulsory licensing and for some flexibilities in the TRIPS. So TRIPS had legitimized this flexibility. Flexibility means you don't need to comply with everything. You can judge. So it gives you some, and one of the most noted, but not the only one, flexibility is the use of compulsory licensing. You basically go and tell the manufacturer, we're going to license it, or you have to license it, and whether he does it or not, it's done. Okay, if the government decides, they can. Okay, and the government will compensate, or it's subject to some compensation, but usually very low price, very low compensation. Okay, so TRIPS flexibilities, and I'll mention some others, legitimized by the Doha Declaration on TRIPS and Health. It basically says you are allowed, if there is a health emergency, public health emergency, you're allowed to deal with it. Okay.
Sorry to do this, but some of these students are in Green College and they have to,
I'll finish.
So I just want to make sure we have time for questions.
Okay. If I had the time, as I said, I realized that I wouldn't. And in fact, I was going to start with the conclusion, but I'll go to the conclusion right now. So political economy of pharmaceutical policies, when you look at my notes, you will find the different agencies and what they're pushing for and not. And you can also imagine, I already mentioned it in the beginning. And what are the key conclusions? Apart from the idea that not just this paper is a work in process, but affordable medicine is a work in process. Okay, so first of all, formal tools of coordinated compliance available under the Doha Declaration of TRIPS and Health. And by the way, these things may be, you can decide that it's not all but just compulsory, but you may decide that it has the new introduction of a new drug requires big degree of innovativeness. You can't just take the same formula, add the little things, or you can't even sometime, or your alternative, you can have a higher standard. It says, here is something that does a good job. You cannot get a patent if you just improve, for example, the way it's formulated, the way it's administered, which is more convenient. So there are all kind of ways of reducing which are discussed, okay, or which are mentioned at least. Okay, so formal tools of coordinated compliance available under the Doha Declaration of TRIPS and Health have been adopted by China, but not employed largely because, and by the way, a Chinese newspaper last year actually had it and accused the government of pandering to foreign investors, okay, in terms of drugs. So this is something that is simmering there. So again, have adopted China, but not employed largely because of conflicting government objectives. This tension between FDI and R&D, and uncoordinated rather than coordinated compliance resulting from fragmentation of drug registration and the patenting regulatory systems. That is the lack of connect, right? I register, but I don't ask. Allows for informally providing flexibilities, thus reducing the negative impact on affordability of patent protection, and the pressure, and reducing the pressure to actually do the formal thing that nobody likes, especially drug companies. So maybe we don't really need, they have an instrument within the system that kind of ensures that there is no patenting. Incentive system created by funding schemes of hospital and doctors lead to faulty prescribing and high cost of medicines, and lack of institutional capacity, knowledge, human financial resources constrain the efficacy of policies to provide affordable medicines. The will is there, even a lot of the money is there, not enough of it, but you need to fix the whole. So reform through selective and what is so in order to get reform, you need to deal with the whole system. You can't just, how you run hospital, how you fund them, etc., is part of the story. And finally, reform through selective experimentation, which is being done. They're trying to introduce experiment with different ways of rules and regulations in cities, so it's easier to control. Is working in the sense that there is learning, what is working and what is not. Okay? So I already mentioned the fact that the essential medicine, the list of essential medicines does not seem to work in terms of stopping bad prescribing, inappropriate prescribing. And one of the indicators was the use and the purchase in the pharmacies of antibiotics, which is huge. That's all. Thanks.
So I think it's time for questions, so you could just take your own questions.
What? Sorry?
You could host questions.
Okay. I thought that was so clear that there are no questions.
I have one question.
Yes.
I'm quite confused how the Chinese government do in terms of the dilemma between they have the obligation to the health rights, means you have to provide Chinese people with more cheap medicines, but on the other side they have to, just to stick to the patenting and branding industry from, foreign companies. As you said, the foreign companies has dominated at least 60% of the medical industry. Is there any successful cases or?
Well, look, the Chinese pay a whole lot less. I mean, they are very successful in the sense that it's a balancing act, okay? Now, it's also a bureaucracy, you are a political scientist, so you know everything about muddling through in a political process. And the idea that China is an authoritarian, unitary authoritarian kind of regime, we all know is not the case, that there is a lot of inter-ministry rivalries, etc., and a lot of bargaining and negotiation. Also, by the way, you will find sequential, the flavor of the day. Right now, the public does have demands, and you hear it. In the same time, the vision of people of having the long-term vision, even if it's a health vision, okay? First of all, somebody, Wildavsky, said that, being rich is safer. Okay? So if you can lift, I'm not sure in China, because even the rich choke from the pollution, but the whole idea is if you can lift people from poverty, but would they survive long enough to be lifted? That's a question. So it's a matter, any kind of policy is always negotiations. So that's why, so the story, which I knew I wouldn't get there because it's a few hours story of the political economy, how things are pushed, and also the role, for example, of the new regime, when the new regime is coming. Actually, we have a paper Yoel's paper that actually mentioned some of this kind of process of reform, of consultation, etc. It's a paper with Pittman that actually described this kind of muddling through in the system, and where the public also participates, sort of in a constrained kind of way. But so I'm trying to say they're getting with difficulty, but every time there is a problem, epidemics of something, and concern for health, this, health concerns receive a lot of attention, and then this kind of criticism in the newspapers that are allowed, okay? They basically accuse the government for not in corruption, etc. Now, it also requires some money, and it takes time, okay? So I don't know. Did Yoel? I will ask Yoel, who sort of looked more recent data. Do you know whether there is a suggestion of how to fund the hospital, which actually is? I know that in the experiments there is, but it's easy to fund a few experiments, and you say, okay, I will give you now the money. Let's see if it works. Yes, it does. Okay, but we don't have money to give all hospitals. There are huge amounts of hospitals. So what do you do? Okay, so you try to push. That's why I said the experimentation actually works, but works slowly. Partly because you don't try to implement the policy in all China. I mean, in Singapore, everyone says Singapore is so successful. It's well, you have a little city, nicely controlled and so it's easier to deal with it. Go to China. Ruling China is not an easy task. I mean, now I'm not crying for this guy. I mean, who ran it, but I'm just saying, running this kind of large system without many resources, and you have problems of corruption and all those other things, and it's difficult. But I think there is progress. That's why I started with the optimistic view, and I just got the bad messages later in the paper, because I think we should not forget that China made tremendous progress. But now when we come, look at the American system. Okay, I could have, we could have come and said affordable medicine is not affordable to quarter of the, I don't know if quarter, but at least to 20% of the people who don't have insurance in the U.S. Okay, so China in this sense is ahead. Okay, so it's not all about money, but. What?
It's mostly about money.
Oh, well, this was, by the way, I have to, given your spiritual kind of leadership, I have to be careful to say it's all about money. And I don't want to give a bad impression about soda. We have even a sustainability center. Okay. But anyway, was it an answer? It's very difficult. But they're making progress. And by the way, I studied China, which is more difficult to study, after studying India. I'm still sort of finishing the India side as well. But the story in China is less depressing than the story in India. Okay? So there, the patent office actually also does not use the flexibilities. Some of it is lack of capacity. Some of it is because, they get a lot of advisors which are foreign, who advise them and try to and sort of instill foreign norms in the agency. And, there are a variety of other things. And the achievement of India are not impressive. So China at least is moving there. Okay? Thank you very much for listening. I wish I had another 2 hours, but I took the risk.
I just want to remind people that the next session is on Monday, March 18th. If I'm reading this correctly. March 18th, and that will be with Professor Wan Yanhai, who has been a visiting scholar here as one of the leading activists and journalists and scholars on AIDS, HIV policy and protection in China. Oh. So that will be a very interesting session. That's on Monday, March 18th. So I encourage people to attend that.
So is he from China?
Yes. He's no longer welcome in China. But
that does happen.
He will be very articulate and really terrific.
That's March 18th?
That's March 18th.
Good.
And in the meantime, please join me in thanking Professor Ilan.
I have to clap to you for listening.